Medicaid is a U.S. healthcare program that finances the care of low-income and certain high-risk populations, including low-income children and families, people with developmental or physical disabilities, low-income nursing home residents, and others. Unlike Medicare, which is a federally funded and administered health insurance program available to everyone over 65, regardless of income, Medicaid is a need-based program funded jointly by the federal and state governments and administered at the state level. In 2009, Medicaid financed the care for nearly 20% of all Americans, making it the largest source of medical coverage for the country's low-income population. In the coming years, under the Patient Protection and Affordable Care Act, Medicaid will expand to cover a much larger proportion of the population in certain states. And yet, despite the growing importance of Medicaid, most Americans do not understand how it is funded. Medicaid begins with a mix of federal and state funding. The federal government makes annual Medicaid payments to states based on their Federal Medical Assistance Percentages, or FMAPs. Each state's FMAP, which is determined by a formula that looks at state per capita income relative to the U.S. average, is set somewhere between 50 and 83%. This means the federal government pays between 50 and 83 cents of every Medicaid dollar, leaving the state to pay the difference. While the proportion of federal and state dollars is set each year, the total amount is unlimited unless the state and federal government have agreed to special financing terms under a waiver of the Medicaid rules. These funds can be further supplemented through a number of different federal grants. A state may use alternative sources of income, such as tobacco or provider taxes, to fund its Medicaid program. This accumulated pool of healthcare money helps to fund the populations in a given state. If people have other sources of healthcare funding, such as Medicare or employer-sponsored insurance, those parties may have to provide funding before Medicaid, since Medicaid is a payer of last resort. While the federal government has mandated legal minimums for Medicaid, including minimum access to care, eligibility requirements, and medical service requirements, there remains great flexibility from one state to another in how programs are administered. One of the ways states utilize this flexibility is through waivers, which allow for expanded services and enrollment, and in some cases allow innovative solutions. Each state establishes the reimbursement rate that will be paid to hospitals, physicians, pharmacies, and other healthcare providers. Medicaid reimbursement rates are typically lower than those paid by Medicare and commercial health insurance carriers. While most Medicaid payments are made to providers based on the services performed, other financing components sometimes complicate the picture. These may include special payments to providers that provide care to a high number of low-income populations, rebates paid from the pharmaceutical companies to state and federal government, or clawback payments made by the states to the federal government to offset the cost of prescription drug coverage offered under Medicare Part D. Adding another layer of complexity, the Patient Protection and Affordable Care Act will expand Medicaid to a larger percentage of those who are currently uninsured, as well as to other low-income individuals. The Medicaid expansion population will be paid at 100% by the federal government for calendar years 2014 through 2016. However, this federal contribution decreases over time, with the federal government paying 90% and the states paying 10%, beginning in calendar year 2020. In addition to expanding Medicaid coverage to new populations, new financial requirements for both state and federal governments will add to an already complex system that is projected to grow to more than $900 billion by 2020.
Our country has a due diligence to be able to support some of the families that really are looking for long-term health care to be able to allow their kids to be able to have the same type of medical benefits as others around the country.
This pie chart shows the health insurance coverage of the total United States population. Out of the whole U.S., only 16% of the health insurance coverage is distributed to Medicaid.
When you go to the doctor's office, they ask you about your insurance, and then at that point you're being judged after that. So I do think they get treated somewhat differently.
This pie chart shows on the left the amount of people that apply for Medicaid in the United States, and on the right how much of the fund for Medicaid is spent on certain people. 44% of the Medicaid spending is used on the blind and disabled, and 21% is distributed to children, the rest split between adults and aged.
I was forced to apply for Medicaid due to the fact that I have no income and I'm a minor. I qualify because I don't have an income and I wasn't able to buy a private policy. The doctors aren't as nice. My first visit wasn't amazing. The office on the outside is very nice looking, and then you walk in and it's gross and dirty. Everything is in Spanish. There's barely any English in there. To me, that makes it seem like because I'm white, I can afford things and I don't need Medicaid. They take forever and they talk down to you as if you're stupid and don't know how to take care of your child. The only thing I can think of treatment-wise is that at a year and at 2 years old, my child would have to get her blood drawn to test for lead because she's on Medicaid. And I don't just mean a little finger prick. They draw blood from their forearm and their veins are hard to find. It's horrible and all because she's on Medicaid. We went to the Texas office in McKinney and got on the computer they had and applied. We could have done it at home on the computer, but we didn't know that. It's actually been really helpful, but only because they paid for all of her hospital medical bills. Other than that, we haven't used it, but they are paying for her part of the hospital bills.
This graph demonstrates how throughout the years, the amount of Texas physicians who accept Medicaid patients has significantly dropped due to the fact that Medicaid patients are unable to bring in a substantial amount of income for the treatment being provided.
That person in need deserves care regardless of their ability to pay.
Some of the patients who show up here aren't technically uninsured. They're covered by Medicaid, which is the government's insurance program for the poor. So why come to a free clinic?
Okay.
Medicaid recipients often have a lot of trouble finding anyone who will treat them because the program pays doctors so little. In fact, Eck only sees Medicaid patients in her volunteer clinic because she can't afford to treat them in her private practice.
If you're getting reimbursed $17 for a visit, it won't be long before you have to close your doors because you can't pay your staff. I'm not sure who gets paid, but somebody is getting all that money, and it's not those who actually touch the patients.
A card that says you have health insurance is not health care.
Ovik Roy is a senior fellow at the New York City-based think tank, the Manhattan Institute, and he specializes in healthcare policy.
All too often, people who claim to care for the poor say, I'm going to give you this card that says you have health insurance. My work is done. You figure it out. But the hard work is actually making sure that person gets treated.
Thank you so much.
Oh, you're welcome.
And I'm done, right? I can go now.
For one thing, Medicaid recipients are more likely to die of cancer.
Because they can't see doctors. They get diagnosed later at a stage of the disease where it's too late and they can't be cured.
That's the implication of a study published in the Journal of the National Cancer Institute, which found that when compared to the privately insured, Medicaid recipients were more likely to have late-stage cancer when first diagnosed. It's also difficult for Medicaid patients to find qualified surgeons who will treat them. A University of Virginia study found that when Medicaid patients checked into the hospital for surgery, they were about twice as likely as the privately insured to die there. Even patients with no insurance were more likely to make it out of the hospital alive than Medicaid recipients. Because President Obama and much of Congress are concerned primarily with the symbolism of providing all Americans with health insurance, Medicaid is about to get a whole lot bigger, despite its failings.
Our children, they're going to grow up knowing that a man named Barack Obama put the final girder in the framework for a social network in this country to provide the single most important element of what people need, and that is access to good health. Mr.
Obamacare has made it so that millions of people will be eligible to enroll for Medicaid for the first time next year. But the Supreme Court ruled that states don't have to participate in Obamacare's Medicaid expansion. So far, the governors of 19 states have come out against expanding Medicaid, even though it means turning down federal money.
The alternative is not to abandon the poor. The alternative is to allow the poor to get the same high-quality health care that most Americans enjoy through the private insurance system.
So what's the best way to accomplish that without spending more money that we don't have? Roy says the federal government should take all the money it devotes to the program and simply give it to states so they can experiment with healthcare plans in which the patient's in control.
And let them spend it on the doctor of their choice. Or maybe, you know what, maybe they're healthy and they'd rather have a high deductible health insurance plan with a health savings account. Some people do want those things, right? You know, let people take the money and get the bureaucrats out of the way, and you'll find suddenly that there's a lot more efficiency in the way people actually get health care.
Eck, on the other hand, believes charity care could be a big part of the solution. If only the government helped incentivize more doctors to volunteer their time.
Our idea is to have the state cover us for medical malpractice for our private practices if we volunteer a certain amount of time, like 4 hours a week. Every doctor I talk to says, I would do that in a heartbeat.
Eck has worked with New Jersey Senator Robert Singer, who's co-sponsored a bill that would put this plan into effect in New Jersey, and it's currently waiting consideration by the Senate's Health Care Committee. In the meantime, come next year when Obamacare takes full effect, charitable clinics like hers will be more essential than ever to pick up the slack for a social safety net that's just not working.
I volunteer 6 hours a week. I've been doing it since 2003, so that's 9 years. And I honestly say I come away each time feeling good that I was able to make a difference.
The bar graph shown illustrates the amount of Texas citizens who are uninsured in major cities due to the fact that the process of applying to Medicaid is so tedious, leaving them to not be qualified and denied the right of treatment.
Texas began participating in Medicaid in 1967. Medicaid eligibility originally was restricted to people receiving assistance from the government with welfare and Social Security. A drastic increase in the Texas Medicaid population resulted from Congress's expansion of the eligibility restrictions in the 1980s and the early 1990s. As of right now, in the year 2017, the numbers of residents relying on Medicaid continues to grow. Approximately 4.7 million people, 16% of the state's population, rely on Medicaid for health insurance. This includes residents with disabilities, residents over the age of 65, children, low-income families, and pregnant women. Texas has not expanded Medicaid under the Affordable Care Act created under Obama's presidency, also known as Obamacare. Tied with Alabama, Texas has the most stringent eligibility for non-disabled adults. As a result of this, Texas has the biggest coverage gap, also known as the donut hole, meaning that many adults have incomes above the Medicaid eligibility, so they don't qualify for any of the cost-effective solutions for healthcare. Many of these individuals remain uninsured, so emergency rooms are having to provide $5.5 billion in uncompensated care each year. Texas residents who are uninsured, or even if they have Medicaid, struggle to see medical specialists, leading them to go to the ER. Political leaders in Texas have remained mostly uninterested in expanding Medicaid. Instead, they have been pushing to secure ongoing funding to cover uncompensated care in the state. By refusing Medicaid expansion under the ACA, Texas not only widens the coverage gap, it also misses out on billions of federal funding that would have provided medical care to low-income residents. The eligibility restrictions on Medicaid not only make it difficult for low-income residents to receive quality Medicare, it also makes it impossible for residents to receive medical care at all.
The chart illustrates the qualifications needed to qualify for Medicaid. It gives examples of family sizes and the incomes required for those families inquiring about Medicaid.
Tonight, Republicans in the Texas Senate are asking for more flexibility in running the state's Medicaid program. KFDM's Sarai Demeen investigates how doctors and patients are reacting to the possible change.
I'm having a problem with my tooth. I have an appointment on Friday.
Selena Tubbs is at the Main Street Medical Center in Vidor.
It took about 7 years to get Medicaid. I kept getting turned down, and I just didn't go to the doctor. You know, when I was sick, I just tough it out.
Dr. Duncan Bowl sees a lot of Medicaid patients.
There's a huge need for Medicaid, and somebody has to look after them. And in this community, most of it is me.
But he can't solve all of his patients' problems.
My biggest problem with Medicaid is getting specialists to see my patients.
The reason he thinks is the cost.
I can see where the specialists come from, too, because Medicaid really doesn't pay as well as other insurances doesn't.
Dr. David Tischer does not think the proposed $100 million expansion alone will prompt more doctors to take Medicaid patients.
More money doesn't mean expanded number of lives. What they're looking for is they're going to have more money just to meet the current coverage criteria, the eligibility criteria, because of the expanding size of the pool of citizens.
Several Texas senators are asking for more flexibility in managing the state's Medicaid program before they'd even consider any expansion of the program.
They're willing to put another $100 million in, and the administration is willing to give them flexibility. I think you would have more folks who would actually have coverage that would give them access to a doctor's office as opposed to access to the emergency room.
An outcome doctors say is good for patients. It's how to get to that point that remains a focus of debate. In Beaumont, Sarai Dameen, KFDM 6 News.
Texas senators say the program accounts for about 1/3 of the state budget.